Just to start off today, obviously this is our first session of the Drug and Alcohol Research and Innovation Active Learning Group. To those who are internal to St Vincent's Hospital, this was previously the Active Learning Network sessions, but this year in 2022, we've expanded our audience out to, we're now partnering with NCCRED, so the National Centre for Clinical Research into Emerging Drugs, who are helping us in terms of presentations and organisation and coordination as well. And we've also opened up DARIA to all our St Vincent's Alcohol and Drug Telehealth Service partners this year as well. So thank you everyone for joining us today. Our clinical lead for DARIA, for anyone who doesn't know him, is Dr. Krista. And then the project management and coordination is being headed by myself. I'm Lucy. I'm the ADS project officer at St Vincent's. Our clinical director, Professor Nadine Ezard. And then our admin, our DARIA admin, is Attica Siddiqui, who is the admin officer for the Alcohol and Drug Telehealth Service. So welcome everyone, and thanks to everybody who's been helping put this together so far. And hopefully today is an excellent presentation, which I'm sure it will be. So our presenter today is Dr. Krista Siefried. Dr. Krista is the clinical research lead and Deputy Director at the National Centre for Clinical Research on Emerging Drugs. She's also a lecturer at the National Drug and Alcohol Research Centre at the University of New South Wales, and she's a research fellow at St Vincent's Hospital, Sydney Drug and Alcohol Service. So Krista's research program focuses on clinical research to address methamphetamine use disorder, including novel pharmacotherapies, and her work aims to improve clinical outcomes amongst marginalised and vulnerable populations. So Dr. Krista is our first presenter for DARIA 2022 this year, and her presentation today is on pharmacotherapy for methamphetamine use disorder. And I'll hand over to Krista now to start the presentation. Thank you.
Thanks, everybody, and thank you for coming. Thanks, everyone, and thank you for coming to our inaugural meeting for this new DARIA group. I do have to say that my preference has always been that when I'm doing a talk, I can deliver it face-to-face and that you can interrupt me and ask me questions throughout. But I am aware that the Zoom webinar doesn't work quite that way, but I do encourage you to please drop a question. If you look at the bottom of your screen, there should be a Q&A text area where you can feel free to pop any questions in, although I can't promise that I'll be able to monitor them through the talk. So I will probably have to answer them at the end. That being said, if there's any technology issues, please put them in the chat so that Lucy can let me know and we can try and fix those up whilst we're here. And I just want to thank you all for coming along. So my talk today, I will start by making sure that I can, there we go. Yep, work my slides. So I will start with an acknowledgement of country, and I acknowledge that I am on the lands of the Gadigal people of the Eora Nation. And I would like to recognize the strength and resilience of those people who maintain a continuing connection to the lands and waters in this region, and that is a right and responsibility that was never ceded. I also acknowledge the traditional owners and caretakers of the nations throughout Australia and pay my respects to elders past and present and the Aboriginal and Torres Strait Islander people here today. And I'd encourage you to maybe just pop in the chat what lands you're joining us from today as well. I think that that could be a really important, nice way to start the meeting. Disclosures, I am employed by NCCRED. I have an honorary appointment at St Vincent's. I'm funded by the Department of Health, the Australian Department of Health, and I'm a lead and associate investigator on studies as per the slides that I discussed today. By way of background, the National Centre for Clinical Research on Emerging Drugs, partnering today on the new DARIA seminar series, was initially set up through the National ICE Action Strategy, and we are funded through the National ICE Action Strategy. It's governed by a consortium made up of the University of New South Wales, St Vincent's Health Australia, Curtin and Flinders universities. Our key aims at the centre are to collaborate, generate and translate. So to collaborate towards building new networks, to generate new evidence base, and to translate that evidence into interactive and responsive knowledge translation products. So pleased to be here today to present some of that work here today. NCCRED achieves these through a program of research funding, seed funding, scholarships, and through the Prompt Response Network, which all of those things will probably feature in future presentations at DARIA. So when we were establishing NCCRED, we actually undertook a comprehensive and inclusive clinical research priority setting study. So recognizing that we had funding through the Department of Health and that the topic itself of methamphetamine or methamphetamine use disorder, as well as emerging drugs of concern, which we were funded for, is quite broad. We actually undertook a clinical research priority setting study, and we went out and did a survey and a literature review and a stakeholder panel. It was a 4-phase study. It was inclusive of people with lived experience, concerned others, families, caregivers, friends. And we came up with a list of priorities in both domains of emerging drugs of concern as well as methamphetamine. And so part of the methamphetamine, one of the key priorities to come out of this study was actually pilot medication trials for adults seeking treatment. So anytime that you start thinking about a new study for a new drug, it's a good idea to obviously go back and look at what's already been done, what ways things are being done, et cetera. And so this talk today outlines some of the work we did in setting up towards that aim. And then I will also go ahead and review which pilot medication trials and other medication trials we are either embarking on, have undertaken, or collaborating with or funded through NCCRED. So just by way of background and acknowledging that there's a sort of a broad range of stakeholders on this call. So background, just briefly, a couple slides to talk about methamphetamine overall prevalence and health burden and some of the pharmacology. So Australia actually has the highest rate of amphetamine or methamphetamine dependence globally. And the number of people in Australia seeking treatment for amphetamine or methamphetamine use has steadily increased over the past decade. So you can see that that's the purple line there. That's the treatment episodes in Australia over time. Standard of care generally involves psychosocial therapy to assist in reducing methamphetamine use or harms. This psychosocial therapy or talk therapy has demonstrated modest effect, but is often not sustained following cessation of that treatment. There are no evidence-based pharmacotherapies for methamphetamine use disorder. Again, we'll go into this a little bit in the next couple of slides, but essentially, methamphetamine use disorder remains a problem in our communities in Australia, globally as well, but we're just focusing locally for the most of this talk. And also just to mention that there are other subpopulations that are more impacted presently. So for example, the MAD data project, which NCCRED funded, and I've collaborated with those colleagues on pulling together some data, demonstrates the proportion of people taking methamphetamine who are in OAT is also increasing. So a little bit of background as well on the pharmacology of methamphetamine. So methamphetamine itself increases the activation of dopamine, norepinephrine, and serotonin. And it can release dopamine into the synaptic cleft, which increases dopamine concentration, and abnormally high concentration of dopamine contributes to the neurotoxicity that we can see with methamphetamine. Norepinephrine itself has effects on increasing your heart rate, your blood pressure. So that's some of the physiological effects that you might see in your clients who are taking methamphetamine. Toxicity or overdose is in, I'm not sure if it's too small to see on the screen, but there's a little figure off to the right there that talks about some of the effects that can be seen in somebody who's taken a lot of methamphetamine over time, especially, and the long recovery period. So that's that MRI image in the corner, which I don't know if it's very clear on the slide. On the screen, the left-hand side is a normal control. The middle, whilst I don't like the language of this publication, it's not my imagery, so I'm borrowing the language that was in the publication. The middle image is somebody who's taking methamphetamines, and the right-hand image is a recovery photo of their imaging 14 months following abstinence from methamphetamine. So you can see that the trajectory back to a normal healthy control image is quite protracted. So for this talk, we're focusing on pharmacotherapies of methamphetamine use disorder, but I don't think that we can really start talking about that without backgrounding some of the other treatments and some of the other modalities that are either currently the best evidence base, currently being used or being studied or investigated in other domains. So for example, here we have psychosocial therapies or talk therapies, they might be known as. So in one systematic review, studies of psychosocial therapies demonstrated overall improvement in treatment and control conditions for decreasing methamphetamine use. So treatment and control. Obviously, this means people who are getting the active therapy, as well as people who are in a control group who might be getting a different modality, et cetera. So probably a bit of an impact of being able to sit and talk to somebody at all. So that's probably demonstrating that any talk therapy is actually better than nothing. So more intensive treatment did demonstrate higher efficacy than minimal treatment, and the effect was generally lost after the intervention ceases. So when the psychosocial therapy stops, the effect tends to be lost as well. The best research for methamphetamine use disorder sits with cognitive behavioral therapy, motivational interviewing, ACT, and contingency management. So cognitive behavioral therapy, there are data on 2 to 4 session CBT in a manualized approach, which reduced amphetamine use. So this is before the sort of prevalence trends tended to be more into methamphetamine rather than amphetamine. So there's a bit of a lack in the data there, letting us know how effective that actually is with methamphetamine use disorder as opposed to amphetamine. In one Victorian study of telehealth CBT recently conducted by colleagues at Turning Point, it's called Ready to Change. They had 40 callers for methamphetamine and found that telehealth CBT reduced drug-related problem severity amongst callers to the service. So that I stuck in there when I was updating the slides for this talk, just thinking about some of the modalities that have changed over time, particularly given the COVID experience. So telehealth does seem to have some impact when delivering CBT via those telehealth modalities. Motivational interviewing plus cognitive behavioral therapy, 2 to 4 sessions CBT plus MI. So again, delivered together, improved methamphetamine absence rates versus minimal care conditions. ACT, which is a mindfulness-based therapy similar to CBT in terms of efficacy for methamphetamine use disorder. And contingency management, I've stuck a few references in there because I think that this is an important one. That final reference is from a systematic review of contingency management in 2020. And I'm actually just going to read you what the authors said there. They said several factors, most notably problem severity, appear to predict treatment outcome, but the effectiveness of contingency management has been demonstrated in studies restricted to many have sex with men, restricted to implementing in the community, and in studies of the general population of methamphetamine consumers conducted in research treatment programs. And there appears to be a broad benefit across all of those populations. So why did I highlight that there is because it's a really underused or underutilized resource that we have good data for. So contingency management has good data and low frequency of use. So I'm just going to pop that into your minds when you're moving forward with your practice. It's a hard one to convince people to fund, and it's a hard one to convince people to get on board, but the data does stack up in favor of it. So why we don't use it more is perhaps a question moving forward. And then in terms of novel therapies, so this is a slide that was presented at APSAD in 2021 as a protocol paper. This is a new study that is being undertaken in Newcastle by our colleagues, including Booty and Adrian Dunlop. This is a protocol for theta burst transcranial magnetic stimulation for methamphetamine use disorder. So this is a feasibility study. So the primary outcome is feasibility. So it'll be a small sample size, but they did receive an NCCRED seed funding grant to conduct this research. And again, in acknowledging that this talk is about pharmacotherapies, I just think to round out some of the discussion, just to sort of keep our eyes on other things that are happening besides just pharmacotherapies. And at that end, I won't be going into in this talk, but just in terms of scope and time. But there are also studies looking at monoclonal antibodies and vaccine studies for methamphetamine use disorder and prevention. So to start off with the pharmacotherapies, we actually undertook a systematic review. So that's where we had very clear set criteria for eligibility for studies that have been conducted for all time points since the beginning of studies being published and open for literature access. And what we did was we systematically reviewed those data for examining them to see which pharmacotherapies have been studied, and for a whole bunch of parameters assessed them for their outcomes. So this was conducted in 2020. And this study actually looked at 43 studies. So what we did was we looked at all the thousands of papers that have been reported, that are in the literature, and we found 43 studies that met our criteria for eligibility. So predominantly for our criteria, it was that the studies had to be randomized. They had to be placebo controlled. So one group got the active drug that was being studied and one group got a placebo. And then they had to be reporting on outcomes associated with methamphetamine use disorder. So we looked at 43 studies, and those studies reported on 23 pharmacotherapies. And the publication for reference actually breaks down what each of the hypotheses are around those 23 pharmacotherapies that were studied. And what we looked at there included things like risk of bias and what kind of things might, if people were randomized. Randomly means that they were equally opportune, there was an equal opportunity to be into the placebo or the intervention group. And what we found was that there was, across all 43 studies, quite a low retention. The studies all had very different outcome measures, which meant that we couldn't undertake sophisticated analyses of the results. So something called a meta-analysis, where we look at a pooled effect size. We weren't able to actually do that because the disparate outcomes. We did find that they were predominantly 3/4 of the studied participants were actually men. So they predominantly reported on men. Many of the studies actually only included men, and so women weren't actually eligible. So there is a big gap in the data in that regard. And we also found that the studies were funded by various, so there were some studies that were undertaken that were not optional, so patients didn't have to give consent. So there were some risks of bias within those data as well. What we did find was that the most consistently positive findings were for stimulant agonist therapy. So those were dexamphetamine and methylphenidate, as well as for naltrexone and topiramate. There were some less consistent benefits with bupropion and mirtazapine, which I will go on to in a second, just about some studies that were published since then. So this review really found that there were not any clear benefits for any pharmacotherapy that has been studied for methamphetamine use disorder. We also touched on withdrawal, which I'll discuss in an upcoming slide as well. So the withdrawal slide. So this slide I won't spend too much time on, because I do believe that Liam Atchison will be presenting these data at a future DARIA meeting. So what we did following that last paper that I just showed you, we undertook a second systematic review, and this one did include a meta-analysis where we looked at 9 studies of 242 participants, and we looked at pharmacotherapies to attenuate withdrawal symptoms. So those pharmacotherapies are listed there. There's obviously far less than 23 from the last slide. So they're listed there, but unfortunately, again, we found a high risk of bias. We found a low quality of evidence and no significant difference between any drug or placebo for measures of discontinuation from study or treatment, from global state, from withdrawal symptoms, craving for methamphetamine, or for safety events. There was one exception, which was ammoneptine. However, this demonstrated a weak effect on discontinuation and global state, but it should be noted that that is not a clinically significant result, because that drug was actually withdrawn from the market in the 1990s due to hepatotoxicity, as well as some concerns about its likelihood to be a drug of abuse. So that study is currently under review, and at a future DARIA meeting, Liam's going to discuss a little bit further about methamphetamine withdrawal. So I encourage you to follow your emails with regards to that upcoming talk. So that systematic review was obviously published now in 2020. It's 2022. So what's happened since 2020? There's actually been quite a bit of activity in the space since 2020, but not a whole lot new to report. So I'll just touch on these studies. Now, unfortunately, these studies, because they were published after the systematic review, I haven't reported them in quite the same level of rigor as what I did in the systematic review when we came to those conclusions about not having very many treatment options at the moment. But nonetheless, I'll touch on just a sort of brief overview of these papers. So the first one was bupropion and naltrexone. So bupropion is an atypical non-tricyclic antidepressant. It's got selective inhibition of reuptake of norepinephrine and dopamine. It's a nicotinic acetylcholine receptor agonist, and naltrexone is an opioid receptor antagonist, which most of you will surely be familiar with. So this study used extended release injectable naltrexone, which is not currently available in Australia, but I do understand that we are talking to manufacturers about potential future options. But in terms of replicating this study in the Australian context, it would be a bit difficult in this current state of not being able to access the same formulations that were given in the study. The study did demonstrate low efficacy, but it was higher amongst the intervention arm than the placebo. So people who received the bupropion and naltrexone did have better rates of abstinence than those in the placebo arm. Mirtazapine has also been looked at. That's an antidepressant. It's an old drug, has a few side effects that I think are probably a little bit harder to take it to participants. However, it did demonstrate in a study of cis men and trans women, all of whom are men who have sex with men, that it did have an effect on reducing methamphetamine use in those who were randomized to mirtazapine as compared to placebo. And I can tell you that this same mirtazapine formulation is being actually replicated in an Australian study that will commence, I think, later in the year, and I'll touch on that in a couple of slides. Another pharmacotherapy that was examined is oxytocin. Again, this is going to come up in a future slide in just a few moments. This is a neuropeptide involved in social attachment. So this was looked at in an RCT, so it was double blind, and participants received either 40 international units of oxytocin, so that was 24 people, or placebo, also 24 people, intranasally. And this was administered prior to motivational interviewing group therapy, and this was given over 6 weekly sessions. All of these study participants, these 48 participants, were also men who have sex with men. Participants receiving oxytocin were more likely to attend the group therapy, 3 times more likely than those who received placebo. There was also some effect on group cohesion, but there wasn't actually any effect on anxiety, methamphetamine craving. There was no change in methamphetamine use, and no serious adverse reactions were reported. So it seemed to help people to get in the door, get them through to the group counseling. Ibutylast has been looked at a couple of times. This did make it into the withdrawal systematic review. This is a drug that's associated with reducing neuroinflammation. In this RCT published last year or late the year before, by judging by my reference at the bottom there, participants received either ibutylast or a placebo for 12 weeks, and there was no difference between these groups for end of treatment abstinence from methamphetamine. Other studies published since that systematic review, there was one on buprenorphine, which you may recognize as an opioid receptor partial agonist and opioid receptor antagonist, also examined by 2 studies in the aforementioned systematic review. This was given in this particular study of 40 participants as a sublingual intervention or a placebo for 8 weeks, and it was given along with the Matrix program for psychosocial therapy. Participants completed the cocaine craving questionnaire and the depression and anxiety stress scale. Both were resulted in lower scores amongst those who were receiving the buprenorphine as opposed to those receiving the placebo. And lastly, a dopaminergic agent that's generally given for Parkinson's disease. This was given for 12 weeks and reported late last year versus placebo, and did result in higher abstinence rates at weeks 7 through 12. I didn't look into this study too thoroughly for this talk, but I did want to pop it in there just for reference. And so those were the international updates. There have been a couple Australian updates as well since that systematic review. N-acetylcysteine, or commonly referred to as NAC, is a cysteine prodrug. And we did have a study led by Professor Rebecca McKetton examining NAC to address glutamate dysregulation associated with drug dependence and reducing methamphetamine cravings. However, her publication that she reported last year, referenced here, actually demonstrated, unfortunately, no difference between NAC and placebo on any measures of methamphetamine use, cravings, severity of dependence, withdrawal, and a whole host of secondary outcomes, some of which are listed there. And some of you may be familiar with the Lima study. So we're kind of holding our breath waiting for these results now. We did finish recruitment last year. This study is an Australian study looking at lisdexamfetamine, which is a prodrug of dexamphetamine. So you may recall from 10 minutes ago when I mentioned in the systematic review that some of those dexamphetamine and methylphenidate in particular had the best signals for efficacy for methamphetamine use disorder. Lisdexamfetamine itself is a prodrug of dexamphetamine. It's licensed for use for ADHD and binge eating disorder at doses of about up to 70 milligrams. And the Lima study actually took these doses that are licensed and increased it substantially up to 250 milligrams. And participants who had methamphetamine use disorder were randomized either to 250 milligrams of lisdexamfetamine or to placebo. So the lisdexamfetamine Lima study will be reporting those results later in the year. However, there was a pilot study ahead of this to demonstrate safety and tolerability of lisdexamfetamine. So this study that is on the slide here is really looking at efficacy measures over time. Sorry, I think I did that backwards. So this study was the pilot study, and here's the Lima study. I do apologize, I got ahead of myself. And we also took lisdexamfetamine for a separate indication and looked at methamphetamine withdrawal, particularly the acute methamphetamine withdrawal, to examine lisdexamfetamine's use in attenuating some of the early symptoms, with the idea that if it was safe and feasible, perhaps eventually it could help people to link into care, get through a detox phase, and get onto whatever step of the next step of their treatment. So kind of a first step in a step care. So recognizing that detox itself is not treatment, and we looked at an inpatient withdrawal. So recognizing that untreated withdrawal symptoms are a barrier to achieving lasting remission. And so we looked at this as an open label single arm trial of tapering lisdexamfetamine. Again, I think that this will be a future DARIA meeting in terms of the actual results, which are currently being analyzed, ready to get reported over the coming weeks. The primary outcomes were safety and feasibility. We had 10 participants. They all started in an inpatient unit at the Gorman unit at St. Vincent's in Sydney with 250 milligrams lisdexamfetamine on day 1, and that tapered by 50 milligrams through to day 5, at which time they would have the option, the participants would have the option of staying in the inpatient unit for day 6 and 7, or transitioning to residential rehab, outpatient care, stimulant treatment program, etc. And then there are a handful of future Australian trials. Many of the current trials are funded through either the NHMRC or through NCCRED seed funding grants. We already spoke about oxytocin, which is associated with social bonding, functioning, and learning. The MOXIE trial is being led by Shalini Arunagiri in Melbourne at Turning Point, and this is an open label single arm pilot study, similar to the study that I reported earlier for methamphetamine use disorder and group therapy. This one is also delivered intranasally. She's using a bit of a lower dose, and it's over 7 days, and is actually being used for women who are experiencing acute methamphetamine withdrawal. So the last study that we just talked about a couple slides ago was only included men. Shalini's study will be focusing on women. The primary outcome is length of stay in withdrawal unit, and this is funded by NCCRED Clinical Research Seed Funding Grant. Mirtazapine, that's the TINA trial that I alluded to earlier. That's Rebecca McKetton. So she's the same person who did the NAC study that we just discussed. This is a phase 3 double-blind randomized placebo-controlled trial of mirtazapine. It's a replication of the mirtazapine study that Coffin did in that previous slide, but hers will not be just enrolling men who have sex with men. This will be a broader population, and in the Australian context. That one was funded by the Medical Research Future Fund. Psilocybin, so at St. Vincent's in Sydney, we're working on a study that Jonathan Brett has developed, an open label single arm pilot study of psilocybin facilitated psychotherapy treatment for adults with methamphetamine use disorder. It's important to remember that this is really taking into account that earlier discussion that we just had around the psychosocial therapies being a really important aspect of care. The best evidence base is actually for the psychosocial therapies. So this study actually includes preparatory and integration psychotherapy sessions with a dosing of psilocybin with a long facilitated psychotherapy session in the middle of those preparatory and integration sessions. That's again funded by an NCCRED clinical research scholarship. Ketamine is another study. You might be familiar with ketamine, moving from sort of a recreational drug into a more therapeutic space in clinical trials. It's an anesthetic originally before it became a recreational drug. The mascot study by Jill Betty at Origin is examining methamphetamine use in young people and providing sub-anesthetic ketamine. It's an open label trial again. So these open label trials aren't the same as the placebo trials we discussed earlier. They don't have a control group. They're really looking at safety and feasibility in smaller populations in an open, so nobody's blinded to the treatment. The administering doctors, the treating team, the psychotherapists, and the participant are all aware of the drug and dose that they're receiving. So in Jill's mascot study, that's 2 subcut doses of ketamine separated by 1 week. And the primary outcomes again are safety and tolerability instead of feasibility in this one. And she's funded through an NCCRED clinical research fellowship. And still with Jill and still at Origin in young people, a study looking at cannabidiol, a non-intoxicating cannabinoid. This is an open label trial, CBD 800 to 1,000 milligrams daily. The primary endpoints, again, safety and tolerability. And again, this has been funded by a clinical research seed funding grant at NCCRED. I guess just to sort of segue and end the discussion and perhaps open up to conversation. I'm not sure how conversation works on a Zoom webinar. That might be something that we need to think through for future sessions, but how to integrate methamphetamine pharmacotherapies. I think it's clear from the data that we have so far is that there is no single solution. There's not going to be a pill that fixes this disorder in any quick format. So there's not currently enough evidence to develop clinical guidelines, probably for psychosocial therapies or for pharmacotherapies. Psychosocial therapies, the research and the data often don't reflect contemporary contexts. So for example, they've been trialed in populations taking amphetamines rather than methamphetamines. So in terms of moving with the market and moving with the current use patterns, they do require high resources. It's a very skilled workforce. Obviously, we are all sort of aware of the delays and the treatment delays and the wait lists, et cetera. Harm reduction is important and probably still some inroads that we could make there. Comorbid mental health treatment, integration of treatment and services for people who use methamphetamine in OAT services and populations. So we just touched on that with the MAD data in one of the earlier slides. An ongoing commitment to clinical research is really imperative. So the National ICE Action Strategy did get refunded in this latest budget. It's important that NCCRED is a very small piece of the National ICE Action Strategy with a very, very tiny cut of that pie, but it is important that that funding continues so that we can continue things like those seed funding programs and the fellowships, the scholarships, and generate new knowledge, create an evidence base, and translate those results, which you'll also see some of the other translational products through the upcoming DARIA seminar series. COVID did interrupt or impact each of the studies presented here. There have been delays, there have been pauses to recruitment, there have been inpatient units that have shut down. I think nobody on this call would be surprised by any of that because obviously your services have all been impacted. So of course, clinical research likewise. The delays do put additional pressures on budget and staff retention, and the number of people seeking treatment for methamphetamine continues to rise. So you can reference Black et al. At the APSAD 2021 conference. So this is despite household surveys indicating that methamphetamine is decreasing overall. and there are different issues with the household surveys in themselves. And I guess I'll hand over for questions. And I do see that the chat box has popped up, and I think there's some great comments from everyone about which lands you're joining us from today. Thank you so much. Really happy that we can have this reach and spread. And then Chris Tremonti has dropped a comment here about good evidence for contingency management, politically too unpopular. It's interesting, and I know that it's difficult to have a conversation on the platform being Zoom and a webinar, but yes, I think it is really politically unpopular, but it's also unpopular with some clinicians and clinically hard to get up. I know I've seen it with contingency management for other work, and I know that there is actually an NCCRED seed funding grant at the moment that's examining thoughts amongst clinicians and consumers around contingency management in an Australian context. So hopefully that study can yield some good evidence that it might be more feasible than what we think. Somebody said, I can't use Q&A, but was wondering what was the most used standard of care pharmacotherapy for methamphetamine. There really isn't one. So any pharmacotherapy for methamphetamine use disorder would be an off-label use of currently licensed medication. So if people have access to a clinical trial, then they may get medication through a clinical trial. There's some off-label prescribing of dexamphetamine. I know that that happens at a number of clinics. And then I guess, there's probably quite a few general practitioners who are aware of the mirtazapine study and could likely prescribe mirtazapine as an antidepressant for that off-label use as well. So I don't know if anyone else wants to drop any other comments about things that you see in your practice or in your services, but please feel free to do that here by way of discussion, because I don't think I can unmute anyone or anything. So I think that's a limitation of the platform, I think.
Yeah, if anybody has any questions or wanted to add to that, there's the Q&A box. You can also use the chat function. I think it would be really interesting to hear, especially from our rural partners that are here today, in terms of what the most commonly used methods are for management of methamphetamine use disorder at your clinics as well, just to get a kind of broader scope of what's going on across the state as well, if anybody wanted to answer that.
Yeah, so Chris has dropped the comment, so sort of just verifying what I was saying about, if there is concomitant depressive disorder, you could trial mirtazapine. It's the easiest to prescribe and on the PBS. Yeah, it's easy. It's an easy off-label prescription. Craig is just acknowledging there in the chat as well. And Chris does outline here in the chat that does come with the obvious caveat that there is still a lack of evidence for efficacy for methamphetamine use disorder. And Chris and Craig, just out of curiosity, do you get lots of feedback from your clients around the side effects of mirtazapine? How do people feel about some of the more common side effects? Oh, we've just got Chris joined us on the panel. Maybe he can unmute. I don't know.
Hello, I feel very privileged to be here.
We've got Chris and Craig on the chat. That's awesome. Great.
Can you hear me, Krista?
I can. Thank you.
Oh, lovely.
What about me? Can you hear me?
Oh, yeah.
I can. Look at the gang's all here.
But firstly, thank you, Krista, for just a wonderful overview. And I would highly encourage, if people haven't, to go and look at Krista, Liam, Nadine, and Nick's paper that goes through these, and which does form the basis for some of the trials that are coming out now, because there is those embers of hope in the methamphetamine fire. I have tried methamphetamine. Methamphetamine.
Prescribing it.
Whoops! I have tried I prescribed mirtazapine. It's funny, patients have sometimes reported having a side effect to it before, and then I've tried it again, and then they don't seem to have such an issue. So I don't know whether they were.
Is it really just sedation though? Is that the side effect?
Sometimes almost like a not an out of body experience, but you know,
Like a depersonalization.
dissociation,
Yeah.
and also a sort of muscle sort of tics and fasciculations, but nothing, you know, as I say, when I've tried it starting at sort of 15 and then slowly gone up, I haven't had issues personally with it. I don't know how much it's changed things, but yeah, but from a methamphetamine point of view, but I've got a couple of people on it at the moment.
So Nadine's just dropped in the comments some of the side effects that I worry about are the ones that Nadine just popped in there around fatigue and sedation. I think you just alluded to that, Chris and Craig, and also the weight gain if people are on it for a lengthy period of time.
Yeah.
Which I suppose could have the metabolic effects as well if people are thinking to be on it for protracted periods.
Sometimes that's actually a good effect, because potentially if people are not eating and underweight and not sleeping, and that's how we sort of use it in people with mood disorders as well.
Yeah, I've definitely sort of, I know you're not meant to use side effects as a reason to prescribe something, but you know, certainly you can tailor your choice a bit if, you know, and if you've got somebody who you feel is a bit emaciated, then Methaphetamine can be a good option.
I don't know if Rob May is on here either, but Methaphetamine's not great for people with anxiety, more so for people with depression. It's my understanding.
Did you say it's not great for people with anxiety, Craig?
Not so much, apparently. It's better for people with more depression type symptoms. But it's sort of hard to nut that out, I guess, when people are using methamphetamine anyway. And I mean, sometimes I think, you know, if there's some symptoms of anxiety with the mood disorder, maybe it's okay. But if it's a pure sort of anxiety disorder, then maybe not as good. But I guess, again, you know, you'd have to take the methamphetamine out of the equation before you could really work that out. But in the beginning, if somebody's, you know, not sleeping and or a bit agitated, then because it's sedating, it sort of tends to be a bit more effective.
If anyone else has got any further questions, please feel free to pop them in the chat box or pop them in the Q&A.
People used to request modafinil back when it was being trialled. Sorry, did you put that on that, Krista? You might have. I missed it if you did.
It was included in the systematic review.
Yeah. Occasionally people still want to ask about that. I think some psychiatrists might prescribe it in the hope that it might work. It's quite expensive, to my understanding.
Krista, we've just had a question pop up in the chat box from Caitlin out at Wagga with her team.
Sorry, just unmute myself there. Would like to know more about acute withdrawal management for methamphetamine use disorder. So is there something in particular that you wanted to touch on, Bron? Or if you were talking about the pharmacotherapies, I guess I could mention in the first instance, there really aren't any pharmacotherapies that are licensed for that use. Certainly there are sort of general benzodiazepines that are prescribed, such as diazepam, for controlling symptoms of agitation or the need to sleep. I'm just getting a little bit echoey, so hopefully you can still hear me.
Presentation. It's more about that acute presentation when they come in, and just kind of managing them over those days. So medications that we use, like the olanzapines, benzos, things like that. Like, so is there a criteria like of exactly what we use and when we use it?
Unfortunately, there isn't. So the best treatment guidelines are from Turning Point, the most up-to-date. New South Wales is currently undertaking an update to their withdrawal guidelines. I don't think that they're going to deviate much from the turning point guidelines, but if you look up the turning point guidelines, they do talk about the diazepam and olanzapine dosing and the sort of maximum daily dose within a 24-hour period. They haven't been trialed exclusively for methamphetamine use disorder and withdrawal, but they're underlying mechanisms of action. It's like saying Panadol hasn't been trialed in several different uses for different pain, but the underlying mechanisms of action are similar. Same with an anti-inflammatory, for example. So the benzodiazepines, really, it's for the agitation, the anxiety, any warnings of psychosis go to olanzapine. I don't know if Craig or Chris wanted to add anything else in there, but if you do take a look at that turning point, those turning point guidelines, I think even within services, there are discrepancies between the maximum sort of daily dose, particularly around the diazepam. I don't know if you wanted to comment, Craig or Chris.
Yeah, look, still most of the treatment is towards symptoms, and as you've identified, it's a situation where none of those treatments have been validated for those, for the specific symptom of agitation caused by methamphetamine withdrawal. So you're quite right, but nonetheless, we still do use ondansetron for nausea, hyoscine for stomach cramps. As for benzodiazepines, I probably for agitation, I do like to trial an atypical antipsychotic in the first instance, like olanzapine, and then if that's not having any benefit, then try some benzodiazepines. But usually I do try to recommend lower doses. I've just had some instances of benzodiazepine dissociation and so forth. And people, not dissociation, disinhibition. So patients becoming a bit disinhibited when they have a lot of benzodiazepine when they've been using methamphetamines. And I mean, ultimately, the difference between alcohol and benzodiazepine withdrawal as opposed to methamphetamines is that the sequelae and the potential consequences are much worse in withdrawal of those two conditions as opposed to methamphetamines, where whilst unpleasant, there's really the risk of death or seizure or anything or really significant sequelae is really minimal. So again, you don't have to. We're not quite so liberal in those situations. Don't know if you want to chime in, Craig.
Oh no, I just highlight your last point. It's not a severe acute withdrawal. I mean, we don't need to sort of necessarily panic about it, like say alcohol with seizures, etc. It's mainly supportive, really, and as Chris said, see what their symptoms are and manage accordingly. But yeah, I tend to go for olanzapine a bit more over diaz as well.
Just in case anyone didn't see it as well, Florence has kindly shared the guidelines, the link to the turning point page with those. So if anyone's interested to have a closer look at those, those are available.
There may be some more guidelines coming out from New South Wales Health this year as well. The last, I think the documents on the website now is from 2006, so they have been updated. I'm not quite sure if there'll be something in there as well.
We conducted a rapid evidence check on behalf of the Sachs Institute last year, and I don't think they'll deviate very much from those turning point guidelines, just because there just really isn't a lot of data. So it really does come back to that supportive symptomatic management. Oh, Florence is just pointing out that the clinical guide for health professionals for methamphetamine guidance notes, that's actually on the NCCRED website. So that's another resource that you might like to take a look at there. She's just popped that. And I think a few people on this call have had some input into those updates. James, thank you for your comment. I'm just trying to see what you're trying to put in there. Oh, you have no volume. Oh no. Oh, how terrible to just look at my slides in my face this whole time. That's awful. We can definitely, we have been recording this. Can I confirm that we've been recording this, Lucy? We can most certainly share the recordings with you.
We can confirm.
Yep, absolutely. I can share the slides. I'm happy to share the slides with you. Lucy can share the recording with you. Should I, maybe I guess if you have no volume, you probably can't hear me saying that. So I might put this as a comment as well.
Oh, yeah, good point. To anyone who can hear us as well, so on the promotional flyer that was distributed, there's a link underneath the Zoom registration link, which is on the NCCRED page, which is where all the recordings of every session will be uploaded if anyone wants to access it again after.
And then before we log off, Lucy, Chris, Florence, I wonder if you wanted to introduce next week's talk so that people can be inspired and motivated to check back in with us next week.
I'll hand over to Chris for that, as Chris is going to be our presenter next week. So I'll let you have a chat about that quickly, Chris. Thanks.
Yeah, so next week I'm going to be talking about microdosing. So in particular, I'm going to be I will be talking about my study, sorry, to bore everybody, but I will discuss a little bit around my study, but I will talk about the phenomena of microdosing across the globe in the sphere of buprenorphine management. In particular, though, I'll be looking at sort of as a way to utilize this as moving people over from methadone to buprenorphine. So hopefully you can all tune in then.
Thank you all for your time. Thank you for watching. And hopefully this is the start of a really awesome program moving forward.
Thank you everyone for attending today. And also, if you have time, once you leave the session, there's just a quick survey that will come up at the end of every single session just to get your feedback on the presentation. So it's just 3 multiple choice questions. If everyone could please take the time to complete that for us. And if there's no further questions, then thank you very much to Dr. Krista Siefried for presenting today. And we look forward to hearing from Dr. Chris Tremonti next week. Thank you everybody for attending.
Thank you. I'm probably still online.
All right, Attica, if you're still there, we can probably end this session and stop the recording as well. Yeah, thanks.
No problem.